replacing dopamine, either by giving levodopa, L-dopa, right, for the past 50 years, that gets into the brain and is converted naturally into dopamine, or by using drugs that mimic dopamine, the dopamine agonists like Mirapex and Requip and Nupro, or drugs that prevent the breakdown of dopamine like Azilect or Comtan. And the new DAT scan that's available in this country for a few years now can show this loss of dopamine. And we can actually see the severe loss of dopamine in the brain that goes along with all these Parkinson's disorders and gives us a reason to try to replace dopamine better. And these types of studies suggest that Parkinson's probably begins 10 or 20 years before diagnosis. And only after 10 or 15 or 20 years is enough dopamine lost where trouble with movement comes out. And it gives us hope that if we could try to diagnose Parkinson's sooner, we might be able to get a medicine that slows Parkinson's down before it ever causes symptoms. We know that Parkinson's probably begins with constipation due to problems in the intestinal tract and a loss of smell and trouble with blood pressure falling. We also know that there's a particular type of sleep disorder where people kick and fight and shout in their sleep. And this can be a sign of early Parkinson's years before. All these types of symptoms we're trying to investigate in people who are at high risk of Parkinson's and don't yet have it to try to understand what triggers people to have Parkinson's disease. Other disorders may occur in a year or two before Parkinson's is diagnosed. Anxiety and depression is very common. Shoulder pain, something like a bursitis, can occur all before we diagnose Parkinson's. When we look back on it, we realize this is really the beginning of Parkinson's in some people. Most people with constipation and bursitis and anxiety and depression and constipation never develop Parkinson's. But we don't know who to pick out who might, that we might be able to treat sooner. And it's not just movement problems, but this anxiety and mood and memory problems and cognitive problems and psychosis with hallucinations or delusions. Some people have apathy and a loss of motivation to get up and go out and do things. People can have aches and pains, especially when the medicine wears down. There's problems with the bladder and the constipation, swallowing and drooling. All these are symptoms of Parkinson's. And we actually have to treat all these different symptoms if we want to do the best that we can do. And it's hard because how many medicines can you actually take to try to help a problem before you wind up causing another problem? So let's talk a little bit about memory and dementia in Parkinson's. Most people who have Parkinson's disease won't develop a dementia. Only about 25% of people will develop trouble with their memory and their thinking that occurs, usually not at first, usually after 5 years or 10 years. It can occur sooner, but usually after 5 or 10 years, some people develop memory problems. By 15 or 20 years of having Parkinson's disease, it may be somewhere between 25%, maybe as high as 30 or 40% in some countries, of people who might develop memory and cognitive problems or even a dementia. The most important thing, I think, to do, though, is to have this monitored over time. We typically do memory tests every year or two to try to tease out when memory problems may first begin. Memory is often a problem just with aging alone. It could be a side effect of medications. It could be a sign of a low thyroid or a vitamin deficiency. It could be a sign of problems with Parkinson's that's not a dementia, just slower thinking that can occur. Or it can be the beginning of a memory problem that can lead to a dementia. So all these have to be monitored over time, and all these things have to be investigated if we find a problem with memory. One of the most clearest ways of knowing if there's a memory problem is by asking about it. So if you notice there could be a memory problem in you, if you have Parkinson's or your loved ones, then we want to do more detailed testing to try to tease that out. And most importantly, when we first get a hint of any memory or thinking problem, we want to reevaluate the medications that are being taken, not just the medicines for Parkinson's, but all the other medicines. So it's very important to either have an updated list or to bring all the medicine bottles in a big plastic bag and let your providers, your doctors and nurses see all those medicines. Because there's medicines that are used for the bladder, medicines that are used for blood pressure, medicines that are used for sleep. All sorts of medicines can cause trouble with memory, especially in people who have Parkinson's disease. Because Parkinson's can make the brain more susceptible to side effects of these other medicines. A lot of our Parkinson's medicines can cause memory problems. And we tend to shy away from medicines called anticholinergics. These are known as Artane or Cogentin, from an older medicine called Selegiline, and of course from dopamine agonists, the Mirapexes and Requips and perhaps even Nupro, because these are more prone to causing memory problems than some of the newer medicines that we have available. Any questions on that?
Yeah.
Yes.
Where does the benefit of Nupro break off and the negative of the memory problems start? He couldn't handle Requip because of compulsiveness and stuff.
Right. So Nupro is a newer dopamine agonist, and because it's a patch, it goes in evenly, and most of the memory problems happen when things go up and down. So someone doesn't like Nupro. But all these medicines can be evaluated by cutting down the dose and seeing if the memory improves. Medicines, levodopa is least likely to cause trouble with memory, except if it's at a high dose. And recent studies suggest Azilect doesn't affect memory in most people. Nupro is much less likely to affect memory than the older Requip or Mirapex as well. Now, what do you do about that? Well, one thing that comes up a lot is this a dementia from Parkinson's, or is this diffuse Lewy body disease? And this can be very tricky to tell the difference. We know that when Parkinson's begins, not only with slower movements, but also with hallucinations or confusion, then we always think about whether it's due to diffuse Lewy body disease and not Parkinson's disease. And we know that when Parkinson's disease affects the movement, but after 2 or 5 or 7 or 10 years the memory is affected, that's usually Parkinson's disease with memory or dementia occurring. Sometimes there's a big overlap though. And what we know is that pathologically, under the microscope, they seem to be the same disease. We only separate them based on these symptoms, but it's not a fair separation, and they're very similar. We treat them the same way, for instance. And this is how we have treatments nowadays for trying to address and treat memory and thinking problems in Parkinson's disease and diffuse Lewy body disease. We always check the blood test for thyroid and vitamin like B12 and make sure that no one's taking a medicine that can affect memory. The Exelon patch has been evaluated in a large study that suggested it may help to a moderate degree the symptoms of memory and thinking in Parkinson's. It's very well tolerated. And the generic Aricept, which is cheaper in a pill formulation for people who don't like spending their money on the Exelon patch or don't like wearing a patch, can also be used, though it's been less studied. Namenda can also be added to these drugs to try to help memory. These very small studies that suggested benefit when added to Aricept or Exelon. These medicines, of course, have been approved initially for the treatment of dementia and Alzheimer's disease. But they also can be used for the dementia that can occur in Parkinson's disease, which is different. But the commonality is that it's not a dopamine problem, but an acetylcholine problem.
Does Namenda have any negative effects, though, on the Parkinson's side?
No, so Namenda does not worsen Parkinson's. Indeed, it was initially developed as a Parkinson's medicine and found not to work. But no, it doesn't worsen Parkinson's, Namenda.
So that's something you could use with Lewy body to help boost the Exelon?
Yes. And there's 2 recent studies in Europe suggest a benefit from that. Axona is a medical food that's sold by a company, and this has not been studied in Parkinson's memory problems, but probably is safe and can be used in combination as a third-line agent. Now, Exelon and Aricept come in different doses, and you should use the highest dose that doesn't cause side effects. Namenda comes in different doses too, and also should be gradually increased. And Axona can be added to that. Much more exciting, though, is a new medicine that's in a research study right now. This is a drug that doesn't yet have a name. And it doesn't go to help acetylcholine like Exelon and Aricept does, or glutamate like Namenda does. It works on a chemical called serotonin. And it works on a particular type of serotonin receptor to try to boost memory and thinking. In this case, in Parkinson's, it also has an ability to lessen hallucinations in Parkinson's and delusions. It's an exciting trial. It's the first study of a drug for Parkinson's dementia in this country. It's sponsored by the Parkinson's Study Group and by the Michael J. Fox Foundation. And we hope that the results of this trial will not only give us benefit in treating these symptoms, but also lead other companies to come and study new medicines in Parkinson's and dementia. And there's 12 sites in the country that's part of this trial. I'm not sure if there's one in Arizona. I believe there's one in the area, though. It's just starting up this month. Other questions on Parkinson's, dementia, memory, thinking, these medicines, or Lewy body disease?
How far along is that study that might be followed?
So there's 12 sites in the country. We were the first site that we have 5 people who volunteered in that trial. And there'll be a total of 60 people in the country who try it first. Right now we're at 5. So over the next year we hope to have the study completed and get some results, see if it's promising to go into larger trials. Now depression is even more common in Parkinson's. Anxiety, depression, not just a full depression, sometimes just a depressed mood. We could lump into that category things like a loss of motivation and initiative that's related, we think, to the loss of dopamine. Probably about 40 or 50% of all people who have Parkinson's disease suffer at some point from depressed mood. Anxiety often occurs when the dose of medicine wears down. And if you have anxiety, even panic attacks happen when dopamine begins to wear down at the end of a dose. You really have to use medicines to keep the dopamine levels up. You can't just treat the anxiety alone. Treating depression and anxiety, though, is important once you've excluded other problems. And again, we check a thyroid and we monitor for depression and anxiety as well. Since everyone needs to exercise almost every day, at least 5 days a week, not having motivation or initiative can be understandable, but you still have to go and do it anyway. And that's the difference between So what do we do about mood and depression and anxiety? Sometimes counseling can help. Getting out and doing activities, walking, going places where people are and being part of groups and activities can help. We do have lots of antidepressants that have been looked at over time in treating the mood problems in Parkinson's. But not with great success, but we use these drugs anyway. We always look for antidepressants with the fewest side effects, like Lexapro and some of the newer ones that are coming down the pike. Some of the older medicines, the tricyclics, can affect memory, so we tend not to use them so much anymore. These are the older amitriptyline and nortriptyline. Some antidepressants have other functions too. So if someone has trouble falling asleep at night and also has depression or anxiety during the day, we might use trazodone or Remeron or tazapine. If someone has low blood pressure and depression, we might use a medicine called Effexor. And the other antidepressants we commonly use would be Lexapro or Celexa, also known as citalopram, or Zoloft. We tend to avoid Paxil because it can affect memory in some people. And there's lots of new ones that we don't have great experience with yet.
What about Seroquel?
We'll get into that. It's a ringer in every crowd.
Perfect.
So we talked a little bit about memory and cognitive problems with or without dementia. We talked about mood and apathy and motivation. All these neuropsychiatric complications of Parkinson's are increasingly important and a target of new drug discovery. Psychosis is also common in Parkinson's. Psychosis means seeing things or hearing things that aren't there, or feeling people are there that aren't there. or having a feeling of paranoia that someone's looking or taking food or money, or infidelity. All the antipsychotics that we have available in this country and elsewhere in the world worsen Parkinson's. Namenda does, and Exelon does, and Exelon can increase tremor a little bit temporarily. But the antipsychotics worsen Parkinson's, and for that reason can really not be used except for two. Seroquel, which causes a lot of sleepiness and doesn't always work so well. Clozaril, or clozapine, that usually works very well, but requires weekly or bi-weekly blood tests for 6 months because it can lower the blood count in the bone marrow, and that's reversible. So it's safe, but it has to be monitored. And there's now the companies that can come to the home every week and check the blood test. So if Seroquel doesn't work, Clozaril should be used because it's very effective in lessening the hallucinations, the agitation, the delusions that can occur in Parkinson's and presumably also in Lewy body disease. Most excitingly, though, are studies that we've recently completed on this new medicine called Nuplazid, also known as pimavanserin. And we were able to report in Lancet, which is like the New England Journal of Medicine in Europe, are the studies that suggest that pimavanserin can stop the psychosis of Parkinson's without causing sleepiness, without needing blood tests, and without worsening Parkinson's. And the company that has this medicine, a small company called Acadia in California, will be submitting all their data to the FDA later this year. And hopefully this will be available to buy next year and will be the most effective medicine. Remarkably, while Seroquel and Clozaril and other older antipsychotics block dopamine to stop this psychosis, the new drug blocks serotonin and really points at a new avenue of trying to treat and understand and prevent psychosis in Parkinson's. We think that probably somewhere up to 50% of all people develop some form of psychosis during the 10 or 20 or more year of having Parkinson's disease. Questions on any of those? So what else is new? Well, we're hard at work with lots of different networks of centers around the country and trying to understand how to slow down Parkinson's disease and prevent it from getting worse, how to stop it or reverse it, in essence, how to cure it. But we don't have good ways of knowing this yet. We really lack a biomarker, a blood test or a urine test or something to try to show us that we're actually slowing down the disease. We're also looking for better ways of treating dyskinesia that don't require surgery and can use medications. There's a couple of new drugs that are in trials right now using a long-acting form of amantadine and using a drug to block serotonin from releasing dopamine. And we're looking at new medicines for these other symptoms of drooling, and there's studies going on for drooling and for constipation in addition to memory and psychosis. The problem is it takes time. It takes a lot of time. Right now there's almost 150 drugs in development looking at new ways of treating Parkinson's disease, and about 100 of these are in clinics now. That means our patients around the country can volunteer in these research programs to try some of these new medicines. But they have to be discovered, they have to be validated in animals, and then they get into healthy humans without Parkinson's to see if they're safe. And then they go into people with Parkinson's who volunteer to find the right dose. And they go into 2 large studies against placebo to see if they really work or not. And then if they pass muster, the FDA weighs in on it. And if they approve it, then it gets sold. So it takes some time. And anyone who has any interest in research programs is encouraged to speak to their doctors to see if they want to be part of these, because it's even longer and more costly and more risky if people aren't part of the studies. Each study takes somewhere between 60 and 300 people in the country to finish the study. It usually takes 3 years to finish a study. If everyone volunteered in the first month, we would move the new drugs up by 3 years. So it's a difficult problem.
But don't a lot of them ask you to be fairly newly diagnosed and not on this and not have deep brain stimulation? You know, I mean, a lot of tough
So
parameters.
every research trial has experimental criteria that you have to meet so that the group of 60 or 300 people are similar. Drugs that are looking to slow down the progression may need people not to be on medicine. But we're doing a study right now on a new Parkinson's vaccine that involves an infusion once a month of antibodies to a protein that we think is involved in causing Parkinson's disease, alpha-synuclein. And people in this trial can be not treated yet or can be treated and just not have fluctuations. So every study is different, and there's lots of studies going on. This slide gives an idea. About 30% of all research trials in Parkinson's never can find one person in the country to join it. Now, most of those are very small trials. 85% of Parkinson's trials finish late, often more than a year late, because of difficulty in recruiting. So it's a problem. Almost 40% of all studies extend the thing because of trouble in recruitment. Right now, if you go onto the computer at either the clinicaltrials.gov or the Fox Trial Finder, a total of 9,000 people with Parkinson's are needed to finish all those trials tomorrow. There's 1 million people with Parkinson's in the country, though, so that's about 1%. And other trials that are just looking to follow people to learn information without giving drugs would require about 40,000 people. So that's why it's so important with the APDA and the other foundations and trying to get the word out of all the opportunities to try to be together and finding new things. The biomarker trials are necessary to see if we can slow down the disease process. LRRK2 is a gene, along with a gene called GBA, that causes Parkinson's in Ashkenazi Jews and in North African Arab Berbers. And this gene is probably the cause of up to 50% of Parkinson's in Jews. And we're following a large group of Jewish patients in South Florida who are at risk of developing Parkinson's because they have this gene, and trying to identify clues on the brain scans, in urine, blood, spinal fluid tests, so that when companies have new medicines to test to see if it can slow down the disease, we'll have something to measure. Measuring this, or how people walk, is not the way to see if a medicine's slowing Parkinson's. We need a blood test like you have in diabetes or thyroid to follow over time, or some other test. And already this large study called PPMI have identified different types of biomarkers that are associated with the beginning of Parkinson's and or the progression of Parkinson's that companies are looking to incorporate in their study. This is a large study called PPMI that's looking with the Michael J. Fox Foundation in trying to find a way of connecting patients along with industry that makes drugs and doctors who treat Parkinson's to find new ways of evaluating the effects of drugs without just the clinical symptoms. I mentioned the Parkinson's vaccine. There's other studies going on in the country to try to slow down the progression of Parkinson's. SURE-PD is a study that raises a chemical in the blood called uric acid. That's an antioxidant. Like people take vitamin E and vitamin C, this is a natural antioxidant that in animals slow down dopamine loss. And this is in humans now. Isradipine is a blood pressure calcium channel blocker that some people take. It's available, but it's being studied in a large trial out of Northwestern University in trying to slow the progression of Parkinson's disease as well. And of course, everyone's looking for some type of gene therapy or stem cell that has not yet been discovered. And we wait for those types of studies. Before I close, let me tell you about some of these other studies going on so you get an idea of how much work is being done to get better treatments for people. Longer-acting levodopa. You might be aware of a new formulation of carbidopa-levodopa called Rytary that's become available over the past 2 months. This lasts somewhere between 4 to 6 hours. Much better and different than the older Sinemet CR, which is not a very effective medication. We're looking for a group of medicines now that don't make Sinemet last longer, but are medicines that work quicker. We call these turning on medicines for people who take a dose of medicine and it takes too long to work because it sits in the stomach too long. We already have had for the past 10 years an injection called Apokyn that can turn people on and improve the symptoms in 8 to 10 minutes. And we're studying now a new form of that apomorphine drug. Instead of an injection, in a lozenge that goes under the tongue and can work very quickly, as well as an inhaled formulation of levodopa. When the medicine wears off, people can take a little puff. It's legal in the study. And they can turn right back on. So these are a new class of turning on medicines. There's a number of drugs being looked at to try to lessen the off time, much like a dopamine agonist or an Azilect can do. We have a group of medicines that work on a new chemical called adenosine. And 2 of these medicines are in clinical trials. One's actually available in Japan, called istradefilin, is being studied here. And a new medicine called tizodonate, which just kicked off its study this past weekend, is being looked at. I mentioned a long-acting amantadine. We have a drug that blocks serotonin neurons from releasing dopamine to stop dyskinesia. So we're looking at that as well. And probably most excitingly are infusion pumps. Up until recently, the only way to stop this fluctuation in people who look like Michael Fox with dyskinesia or Muhammad Ali with trouble moving every 2 to 3 hours was to do brain surgery, the deep brain stimulation. But of course, if you have trouble with memory or psychosis, you can't have deep brain stimulation. In Europe, there's 2 infusion pumps that are available. One is a PEG tube, stomach tube, that can be connected to a pump that puts levodopa in a gel into the stomach over the 16-hour waking day. And this has just been approved here several months ago, called Duopa. And another infusion pump contains the same medicine that's in that apokin injection called apomorphine, and this goes in an insulin-like pump, a tiny little pump with a patch that goes into the skin each morning and keeps everything even over the waking day. And these studies have just begun at our site and in Detroit just this month. And in several months, we'll begin the first studies on a levodopa infusion pump that's put on like an insulin pump every day to try to keep things more even. So a lot of these ways are trying to bypass the idea of swallowing the medicine and has difficulty getting back up into the brain. There's also been a lot of work on norepinephrine, a new drug. Yes?
On right hearing,
Yes.
first of all, to clarify the spelling, R-Y-K-A-R-I?
R-Y-T-A-R-Y.
Thank you. And now, does that have the negative side effects on Lewy body that cinnamon at higher levels can have?
So we don't know that yet, but it's a good point. So I mentioned that Cinemet CR is not a very good medicine for a lot of people who fluctuate, but it's probably the best medicine for people with diffuse Lewy body disease, because you really want to avoid having too much dopamine in that disorder, because it can really tip off confusion and hallucinations. And Rytary comes in very, very low amounts. And much like we use Cinemet CR in diffuse Lewy body disease at half pills and once or twice a day to keep a low level of dopamine, Rytary might be a good choice for that same reason, at the very, very, very low dose. Norepinephrine drug called Northera became available in this country last year. It's been available in Japan for 20 years. This is a medicine called droxidopa. Like levodopa becomes dopamine, droxidopa becomes norepinephrine, noradrenaline. And it's for people who, when they stand up, their blood pressure falls. This so-called orthostatic hypotension. And it's the first treatment, and it's not only for orthostatic hypotension, it's only for orthostatic hypotension in Parkinson's disease and related disorders. So that's a new Parkinson's drug as well. I mentioned the new serotonin drug for psychosis coming next year, Nuplazid. We're also studying some new medicines for constipation that work on serotonin and work on prostaglandins with an injection. There's 2 studies going on for constipation in Parkinson's. It's a big problem, and companies are looking to find solutions for it. And we're also doing studies now in a treatment for drooling in Parkinson's, where we inject a type of botulinum toxin called Myoblock. It's available, it's approved usually by Medicare and insurance, injected into the salivary gland over here. A tiny little injection that stops and reduces drooling for up to 3 months. And finally, this slide just sort of tries to summarize some of what we'll all, in my field, be talking about in San Diego next week as we convene for the movement disorder meeting where we discuss all the new advances and research and new thoughts of what to do next year and the following years in Parkinson's disease. And about 5,000 Parkinson's experts from around the world will go to San Diego at this meeting. We think that treating early is important, and trying to avoid using too much levodopa is important also. Having any symptoms of Parkinson's is probably too little dopamine, but a lot of symptoms could be too much dopamine, like dyskinesia and hallucinations. The only thing that helps medicines work better is daily exercise, at least 5 days a week, we think. And we're very excited by all the new drugs that are being studied by companies really around the world, and trying to treat not only the movement problems of Parkinson's, but some of these non-motor problems of mood and memory and constipation and drooling and all. And the research is really what finds new treatments, so anyone who's interested in that should seek that out as well. I think we've got plenty of time for questions.
Yes, sir. To revisit the psychosis for a minute, why do some bodily infections bring that on?
Yeah.
And I've had personal experience with that. I don't want it to happen again.
Yeah, so it turns out that the common view of doctors is that hallucinations and low blood pressure and sleepiness is due to too much medicine. It's not true. It's due to Parkinson's disease affecting other parts of the brain. And because Parkinson's disease affects other parts of the brain, causing these other symptoms, things can tip it off. Whether it's a new medicine, or too much medicine, or a urine infection, all these things can tip the scales and bring out these symptoms. So if you had polio as a child and you got the flu or urine infection, you'd be weaker in the leg during that time. If you have Parkinson's and you get a urine infection, you can have trouble with these other problems, whether it's low blood pressure or confusion, or the Parkinson's symptoms will be worse with tremor, or dyskinesia will be worse. But that's why. During those times, by the way, if you're susceptible to developing hallucinations when you get sick, let your family know that when you get sick, they should lower your medicines preventively. You can talk to your doctor by how much. Typically in my patients, I'll lower the Cinemet by